Good morning, everybody. My name is Charlie Camus. I'm Director of Clinical Strategy for Women's Health at Boston Scientific. On behalf of Boston Scientific, I would like to thank you for joining us this morning for this session on Solyx single-incision sling. Single-incision sling has had a very interesting and unfortunate history, shaped by the negative experience with TVT Secure and many misconceptions about product effectiveness and the case for its use. It is my pleasure to introduce Dr. Kevin Benson, who is going to be addressing those misconceptions and sharing his extensive clinical experience with Solyx. Without further ado, Dr. Benson.
Well, thank you, Charlie. I appreciate the opportunity today to speak on Solyx. This is a product and a platform which is really near and dear to my heart. I hope that today we can make a compelling argument, really that this is a unique and a forward-thinking platform that's going to allow efficacy and great results for your patients. It's a product that I've worked with now for a number of years, and it's really become my go-to sling for most patients with stress incontinence. So we're going to begin by just laying out a little history, as well as some of the, I think, great characteristics of the sling and some data that we've obtained not only through our studies, but through some cadaver work to kind of show you, I think, a real compelling argument that this is an efficacious sling for you in your practice. So today we're trying to basically outline information for you that will help you in your clinical practice. As always, we want to make sure that we're using devices correctly, that we're following appropriate labeling. And what we're trying to do is just to lay out for you outcomes that are representative of general use with the sling and provide you data that I think is really well balanced and fair. So there's a lot of reasons why physicians are not using single incision slings. And we've outlined a few of these today. The first is really, why should I change slings? And, you know, we could make this argument about slings, about pelvic floor repair, about neuromodulation, about any number of different topics that we are involved with. And there's a complacency, there's a sense of safety, and a track record that slings that you've used for a long time come with. And because of that, I think we really have to present data that's not only as good, but better. And I think that just like with anything that we're doing, we have to always say to ourselves, is what we've done forever really the right thing? Is it really the best for our patients? Or is comfort driving us more than really trying to do something better? So, you know, for me, it was a transition. It was easy to make. I had been a Mini-Arc user in the day when Mini-Arc was available. And for me, it was a kind of a natural transition into the Solyx platform. But I know many of those of you that are listening are currently using retropubic slings, so you're using transobturator slings, and this may be a platform that you just have not approached before. So it's really not equivalent or the same as those other platforms. So today we're going to try to teach you some of the nuances that will allow you to deliver this sling effectively. I think the second argument that's been made is that there's really no data on single incision slings. And that's really no longer true. Today we'll present some data that's been peer-reviewed and I think represents a very good overview of efficacy that's been proven out over time. And I think the third argument that single incision slings are not as effective is absolutely false. In fact, I would argue that the single incision sling, both from the standpoint of efficacy as well as side effect profile, is not only as effective, but is more effective. So one of the things that I really try to encompass in patient care is patient experience. And I've used the analogy previously of, for instance, getting your eyes done, the idea of LASIK. And LASIK, for first blush, is potentially a dangerous procedure. It could effectively blind you. You could effectively have a lifelong complication or vision that may not be right. But we don't really see it that way. Most of us that have had LASIK have more or less said, wow, you know what, I'm going to forego any of the thoughts of what happens behind the scenes but the experience that I'm going to have with this is going to be so wonderful and my outcomes going to be so good that of course I would do it. And I think that some of the things that we take for granted, patients really are not necessarily honed in on. And, you know, again, one of these is patients expect surgical perfection. I think for those of us that perform a procedure, if we perform it well and we've executed it well, we consider that the standard, that we say, wow, you know what, I executed that perfectly. But I think that we have to make the assumption that patients expect that from the get-go. And it's the experience they have that probably ultimately fosters their thought that this went well or not. And I think that with the example of LASIK, patients see a dramatic, safe, and simple improvement. And that's exactly what we're hoping for with a sling procedure. You know, again, we're not treating cancer, we're trying to improve quality of life. And that quality of life, the more dramatic, the quicker it occurs, the more consistent that it is, not only for patients but ourselves, leads to positive reinforcement. And I think it creates a winning situation, not only for us, but for our patients. And I think the last part of the LASIK analogy is that it's presented in a soothing, relaxing environment. And if we're trying to reduce the intervention with a procedure, we really need to kind of remember, what does the patient see? What do they feel? What do they remember? And it's not the incision in their urethra that they remember. It's what was their experience like getting to the OR? What was their experience like in the OR? What was their experience like as they recovered? And did they get back to life as quick and easy as they wanted to? And just like LASIK, I think that this is a potentially an absolute in-office type option. And this is the only platform that I feel that can get you there, that can really allow you to effectively deliver care in a low morbidity, low intervention type setting that can ultimately be done in the office safely. So the question I always ask is not why use a Solyx, but why not use Solyx? And I think that for a long time, we've always tried to come up with an exemption of maybe, well, it might work here, it might work there. At this point in my practice, it's really my go-to first line sling. And so when I am evaluating a patient for sling type and which platform to utilize, the thing I always ask is, why not the Solyx? And I think that, you know, again, the superior experience comes from several facts. The first is that with Solyx, I do now approximately 50% of these strictly under local anesthetic. And again, because of the minimal dissection, the fact that it's not a full thickness through and through sling, it allows me to do it under that platform confidently with patients that are happy with their outcome. I think that secondly, it improves the patient experience. Anytime when that patient experience is better, it's really helping patients come in and get evaluated and get the treatment that they want. It reduces anxiety, both for patients and for physicians, and it ultimately reduces cost. And all of those things on the balance sheet are a positive. And I think we have to remember that consistently, if we can give a patient a better experience, reduce their anxiety, their worry, give them a great outcome and reduce costs, that's a positive thing. And thirdly, I really think that being able to do a Solyx sling with a patient, for instance, under a local anesthetic allows for the most accurate intraoperative assessment of sling placement. So this allows us to give the best degree of sling tensioning. It allows us to be able to test the patient while they're in the operating room. And it really gives us a very good assessment of where that sling is lying to make sure that we've got it placed perfectly. So, you know, one of the things that I have found from my personal experience in working with Solyx that has really, I think, led to the acceptance of this platform for patients, the number one thing is the fact that it's a mechanically fixated sling. And we're going to bring that up again and again through the discussion today, and that is that it doesn't require ingrowth. It doesn't require time. This sling is good to go when you place it. And that really allows the patient to know that confidently they can resume their life. And patients don't need weeks and or months of restrictions and limitations. Again, if you're a 40-year-old patient with 3 kids at home and you're working at Arby's, you don't have 6 weeks to say, okay, I'm not going to, you know, do all of the things that are meaningful in my life so I can have this. It's not that they wouldn't like to, but they simply are not able to, you know, take themselves out of their life for that long of time. And I think that patients beginning normal activities, resuming immediately, is absolutely a game changer. You know, so many patients come to see me and they say, well, I was told I can't do anything more than 5 pounds of lifting for 6 weeks. I'm not able to resume the activities that I want to do. You know, I was a biker before. I was a person who did a lot of cardiac work. I have a physically demanding job. And I think that those are all the things that before a patient ever gets to your door that has negatively impacted their thought on getting their problem corrected. And again, you know, how many patients do you meet that wait a number of years and ultimately then are improved and they say, gosh, you know what, the biggest regret I have with this is that I didn't do this 10 years ago. And I think that you just have to really ask yourself, how many young active patients are untreated due to the limitations that we place upon them due to the technology and the limitations of the technology that we have. And again, you know, at 6, 8, 12 weeks, efficacy may very well be excellent with the other slings. But the problem is it's that transition period, and the limitation during that transition period that really prevents people from coming in, getting evaluated, and improving their life. So to bring up the second point, that there's no data on single incision slings, I'm sure that many of you listening today have had an opportunity to see this study. And again, it was a prospective parallel cohort, multi-center study of Solyx, and it was versus Optrix 2 in treatment of stress incontinence. And it was a three-year trial. And again, Solyx currently does have the most data of any single incision sling on the market. So to essentially frame the study and to give conclusions, I think that the most important thing is that Solyx was found to be non-inferior to the transobturator Optrix 2 sling for long-term treatment of stress incontinence. Side effects following the single incision sling were non-inferior to the adverse events following the Optrix 2 sling, and that both quality of life and disease-specific quality of life markers were improved after both of the slings. And the sexual function was improved with both Solyx and the Optrix, as one would expect. And I think importantly to know that what patients are measuring is their quality of life. They're measuring their sexual function. They're measuring what you might call the soft markers of improvement. And we all know that patients obviously do measure stress incontinence being resolved as one component, but it's not the only component. And again, the rate of de novo dyspareunia was extremely low and uncommon with the sling. So, you know, one of the things that has, I think, really changed my view on the Solyx sling is the fact that it's a mechanically fixated sling. And I think that always the concern has been, does this sling have adequate pullout strength? Is this sling, quote, as strong as the other slings that we utilize? And so what we have done now in a cadaver model is that we demonstrated that the immediate fixation strength compared to retropubic and transobturator sling without tissue ingrowth is higher. And I think that for me, this was really an aha moment. So this is kind of what you might call a real life sort of simulated model. And what we really did was to take an actual cadaver, place these slings as we would clinically, and then used a tensionometer to measure the pullout strength. And this is something that I had been advocating for a long time, because those of you that have used Solyx probably realize that if you try to pull that sling out, most of the time you'll actually fracture the sling, you'll break it away from the anchor before you will ever pull it out of the muscle belly. So essentially, what we used was we used a tensionometer, and we made first a pull from the midline on the sling. So we utilized a clamp, placed it around the sling after the sling had been placed as we would to normally position it, have it in place. And we then did 3 pulls. So we first did a midline pull. So this was essentially providing a pull strength, a steady constant pull until either the sling fractured, it became displaced, or in fact the tensionometer and the clamp literally pulled off of the sling. And we can see that we had 8.36 pounds of force required before the sling distorted. And with this, the sling did not actually displace, it did not actually fracture. The actual clamp pulled off from around the sling. So after we did this, we then said, all right, well, let's see how that the force is distributed from the left and the right side. So again, this was grasping the apron of the sling first from the left side, so off of the midline, and then pulling directly in axis with the anchor. Indeed, it was 7.52 pounds from the left side, and from the right side, 10.82 pounds. And using comparative data with transobturator and retropubics, these numbers are significantly higher, and certainly more than surpass the physiologic ability for a patient to exceed this force. So we then utilized both the retropubic and the transobturator in a similar fashion, and these represent the midline pull strengths. So on the retropubic, you can see it's less than half at about 4.3, and with transobturator even less at 3.3. So if we were to say, which gives you the greatest deal of comfort, which gives you the greatest reassurance that indeed this sling is strong and it's going to stay in place, for me, as I said earlier, this was really an aha moment. It was, you know what, this is at least twice as strong. And in fact, what we found was that in each case, the tensionometer literally pulled off of the sling before we could get it to either fracture or distort. So what we do know, though, about single incision slings is that technique really does matter. And this is a situation where close isn't good enough. This is a situation where you have to have precise, accurate, and perfect placement. And I think that the tool that's been created really allows you the platform to get this sling to where it needs to go. And in a little bit, we're going to show you a video with the procedural steps to kind of outline this. And I think that one thing that's really helpful when placing this sling is to actually break this into a series of steps and to keep those steps compartmentalized. I think that one of our challenges when doing these slings is that we tend to flow everything into one movement. And if we flow everything into one movement, we risk getting off our mark. We risk having deviation that then gets magnified and we may not be aware of it. So I have really found that breaking this into steps, literally taking a pregnant pause and stopping a little bit in between each step to reassess things is helpful. And along with this, what I still do to this day when teaching residents and when working with others, I have a bony model and I have a model with musculature, and I like to do a dry run with a simulated sling beforehand. And it just forces me to really think about the patient positioning, get it to where it needs to be. So certainly, obviously, the key is we want to start in the right place. We want to think about the angle and the orientation of the handle. And as you can see here in the diagram, we want it about 30 degrees off the horizontal. And we are going to be placing it in the midline. Secondly, we want to advance it laterally. And we call this the periurethral parallel push. And what this allows us to do is to follow in the plane of the periurethral dissection to deliver that tip to the medial edge of that obturator muscle so that we're going to be in the exact right position to deploy. Again, the black mark that's on the deployment device is really critical and important to know that it's there for a reason. And I find that many times people are not aware of that mark. They may not look at that mark, but I use that mark every day. And for me, it just really makes sure that I'm where I think I am. It makes sure that I'm in a comfortable position, and I know that I've not either overreached or underpenetrated. So step 2 is critical. And this is something that people in the room, behind, off to the side, etc., can see whether that tip is being delivered where it needs to be. And that's crossing to the contralateral thigh. And again, we want to really sweep that handle across. And if that handle doesn't cross the midline, there's no way that it's going where it needs to be. So this is something that whether you're whether you're a physician watching, whether you're a representative helping, whether you're the person delivering it, that idea of stopping, moving the handle across the midline so you can deploy the tip in the correct plane is so important. And then thirdly, what we want to do is just to advance that trocar, and what you can feel is the loss of resistance. You will feel that anchor go right into that muscle. And when you feel that, again, it's just a feeling of comfort, and it's a very positive feeling that you have when that drops away and you lose resistance. So I want to thank you for the time so far that you've indulged us with to go through a little bit of setting the stage for what's to come. We're going to now show a video that's going to really put into play in live time what we were just showing conceptually. And I think that this is going to give you an idea of what you're looking for with each step so that you can see exactly where you are and make sure that indeed you're thinking about this as in a compartmentalized, stepwise maneuver. The Solyx midurethral sling represents a significant advancement in sling technology. One of the greatest attributes of the Solyx midurethral sling is it is a mechanically fixated sling, which is depicted here with this anchor. However, this also means that we have to be excellent at executing sling placement. If we place a sling in the correct position, pull-out strength surpasses many slings that are available today and provides strength in the sling immediately. The key to placing the Solyx midurethral sling is compartmentalization of steps, and we will outline 3 steps today. One of the errors that we see physicians make in placing the midurethral sling is merging these into one procedure. One needs to really think about these as separate steps, execute each step, and then advance to the next. We'll now depict the 3 steps. I'm going to use a marker to outline roughly the level of the external urethral meatus for a point of reference. On the sling, there is a black mark. This black mark is critical. This allows you to know roughly where the anchor is at, and it allows you to know where the pivot point for placement of the sling is. If one thinks of the sling as a teeter-totter, this is the point in the center of a teeter-totter. This point should not move significantly during deployment of the sling. It should be relatively fixated. And again, this is the point of 0 movement. So the first step that is critical in deployment of the Solyx midurethral sling, parallel periurethral push. And this implies that we are going through the channel that was made through the dissection through the periurethral tissues. And what's critical with this is orientation of the introducer handle, and as that then relates to the proximal portion of the introducer. So the goal with this is not to go medial into the bladder or to go lateral into the pubic bone, but instead to exactly parallel the plane of dissection, hence the parallel periurethral push. And one will advance until the black mark on the introducer is at the medial edge of the incision, taking care not to over-advance to where you can't see the black mark or under-advance to where the black mark is not to the point of dissection. So as one can see, the handle is not moving lateral to medial. It's not moving anterior to posterior. It's moving in a plane parallel to the periurethral dissection. The next step is to proceed contralaterally, termed tail wag, moving with a point of relative fixation of the pivot point or the black mark to allow movement and the trajectory to change to allow the sling to be positioned in the upper medial portion of the obturator fossa. Third step in placement of the midurethral sling after one is across the midline is to advance. And with advancement, the goal is to penetrate the obturator internus muscle perpendicularly. And we can see and hear and feel a pop. At this point, one can see that it is anchored at a perpendicular trajectory to the obturator internus muscle, allowing full fixation strength. If one looks laterally, you can see that this is perpendicular and lying within the obturator internus muscle. And this is key to fixation strength. Errors can lead to lack of success with the Solyx sling. Again, in frame of reference, the anchor provides the fixation strength for this sling. The introducer tool is what really allows us to deploy the anchor in the correct position. Lack of deploying the anchor in the correct position is the #1 reason for lack of success with this sling. The first common error is what I call the superficial deployment. And what this means is if we again use a frame of reference of external urethral meatus incision line here, instead of advancing with cephalad push, one does not do an adequate cephalad push. And if one does not, and now pivots the sling with the tail wag maneuver, one can see that you hit the inferior edge of the pubic ramus. And this is an error made by not deploying deeply enough with cephalad push. So again, the key tool that prevents you from having this error is looking at the black mark and making sure that the black mark is advanced to the medial edge of the incision. So again, lack of cephalad push along with pivoting will deploy the anchor in an attempted placement into the inferior pubic ramus. Second error is excessive cephalad push. So again, when using the frame of reference of the black indicator mark, if one deploys with too much cephalad push until the black mark has disappeared, and now we do the contralateral movement or tail wag maneuver, one can see that you are too high and you've actually passed the obturator fossa and you are now pushing on the internal portion of the pubic bone, cephalad, to the obturator fossa. This will lead to a sling that is not deployable and sling length which will be inadequate for the procedure. The third error is lack of pivoting. Lack after cephalad push occurs is the lack of moving the introducer to the contralateral side to allow perpendicular introduction into the obturator internus muscle. If one does not have the contralateral movement termed tail wag, what will happen is that the anchor will lie in between the endopelvic fascia and the obturator internus muscle. This is not the deployment trajectory necessary to have good fixation within the muscle belly. One can see the anatomy here briefly. This is a open abdominal dissection revealing the pubic symphysis, revealing the external iliac vessels, and the bladder Foley bulb is located here. The obturator neurovascular bundle is located here, obturator internus muscle, and one can see the outline of the obturator foramen. Again, on the contralateral side, neurovascular bundle, obturator internus, and the outline of the obturator foramen. At this point, the patient is positioned in low dorsal lithotomy position and a catheter has been placed. As one can see with traction on the catheter, the bladder neck is discernible. One can see the Foley bulb distending the bladder neck and showing the proximal urethra. Bladder neck is identifiable at this level. Mid-urethra is right here. This is the appropriate level for the dissection to occur. For purposes of demonstration, this is a cadaver with a relatively fixed urethra. In this particular circumstance, it's a little bit more difficult to see given the nature of the urethral anatomy. However, the concept of developing a hydrodissection plane and allowing development of a space for safe dissection is the key takeaway. 10 cc's can be used in the midline of the local anesthetic. Additionally, anesthetic can be placed parallel to the plane of periurethral dissection to develop and to blunt the periurethral angles. A total of anywhere from 10 to 30 cc's can be used depending upon personal technique. At this time, hydrodissection is complete. One can see a bleb underlying the urethra in the midline. One can also see the periurethral sulci that are blunted and brought down, again increasing the level of safety and decreasing the risk of a superficial penetration at the level of the sulcus. The next procedural step is to make an incision over the mid-urethra. This incision in length is approximately 1.5 to 2 centimeters, and the incision overlies the midline of the urethra. Care is taken to ensure the appropriate depth is achieved. One will be aware of the appropriate depth when one can see egress of some of the fluid that was instilled and a lighter appearing change in the plane of dissection. One can see the fluid egressing into the incision at this point, indicating that one is in the correct plane of dissection. At this time, retraction is applied to the incision. One can see the plane of dissection is demonstrated with the clamp and the Metzenbaum scissors. One can see the avascular nature of this plane. At this point, one can dissect parallel to the periurethral tissues, with the goal of the dissection occurring the correct trajectory to follow the periurethral tissues until one reaches the level of the sulcus. At this time, one can look at the length of the Metzenbaum scissors and see that the screw of the scissors is just slightly beyond the plane of dissection and the medial edge of the incision. One can gently spread the jaws of the scissor to facilitate dissection. It's important when doing this dissection to have an adequate width to allow the sling to lie flat within the plane. So at this time, the dissection of the periurethral tissues is occurring. When one goes out with the Metzenbaum scissors, they can actually feel the edge of the bone when one is tapping on the inferior edge of the ramus. So one can feel resistance of the inferior edge of the pubic ramus with the tip of the scissor as one is performing the dissection. The dissection is then carried out on the contralateral side. Again, paying attention to the plane of dissection in the avascular space between the epithelium and the underlying periurethral tissues. Using the jaws of the scissor to perform blunt dissection and to spread the dissection. So the first step in placement of the sling is the parallel periurethral push. In order to do this, we want to pay attention to where the black mark is, advancing it along the plane of dissection until the black mark reaches the incision. This is a very important step, and the black mark allows us to ensure that we have the appropriate depth of penetration. As we do this, one will feel us penetrate through the periurethral tissues. In looking, one can see that the mark is now at the medial edge of the incision.
Okay.
At this time, the parallel periurethral push is complete, and one can see that the black mark is exactly at the edge of the medial portion of the dissection. At this time, we will rotate to end on the contralateral side of the patient, known as the tail wag, to allow the device to now be oriented correctly for penetration into the obturator internus muscle. The black line, again, as you notice, has not moved. It's essentially at the medial edge. No further advancement has taken place at this point. At this time, the next step is advancement. And advancement is to be perpendicular to the obturator internus muscle to allow penetration into the muscle. And at this point, it just penetrated the muscle. And at this point, the sling is anchored. The next step is to detach the anchor from the handle, and one holds the advancement sleeve in place and pulls until a click is obtained, confirming that the introducer tool is free of the anchor. We can now confirm that we're in the appropriate place by applying traction to the sling. And one can see that the anchor is affixed firmly. This can be confirmed on abdominal view, showing that the traction is being applied on the obturator internus. And one notes the positioning of the anchor, which is in the superior medial aspect of the foramen, far from the neurovascular bundle, with a distance of approximately 3 centimeters or more. So a couple of common questions arise once the sling is deployed. And this really has to do with setting the first side of the sling correctly. One common question is, what does it feel like when the sling is anchored appropriately? And the biggest key is that you will feel a buildup of tension as you're penetrating. That buildup of tension will be suddenly lost, a loss of resistance. You have to have that positive confirmatory loss of resistance to know that you're anchored appropriately. If the entire penetration feels the same and there is no gradation or loss of resistance, one has to believe they're not in the appropriate position. The second key question people ask is, how far do you penetrate after the point of loss of resistance? And the answer is to stop as soon as you get to the loss of resistance. One can intentionally continue to push and advance the sling. However, if you do that past the point of resistance, you'll short yourself on the other side. So as soon as the loss of resistance is obtained, you don't need to go any further. So now we're going to deploy the other side of the sling. We'll begin by attaching the anchor to the introducer tool as we've done previously. I've grasped the medial edge of the midurethral incision once again. We will now once again parallel the periurethral tissue dissection with the push, doing the parallel periurethral push. As one can see, we're essentially moving up in a parallel plane to the dissection. As we do this, one will feel a loss of resistance or a pop, and one could just see that. At this time, we're going to go contralateral across the midline, and this is critical. As we do this, it allows us to then set up a perpendicular penetration of the obturator internus muscle. So we will now penetrate and go until we feel that loss of resistance, and we're there. At this time, we will deploy the sheath, thus deploying the sling. One can see that this is an appropriately deployed midurethral sling. It overlies the midurethra and is neither contracting nor lying loose. It has just a slight bit of pillowing. Empirically, this sling looks to be placed in the appropriate position.
So next, you are going to see a comparison and pull-out strength between Solyx and traditional sling, retropubic with advantage fit, and transoperator with Optrix 2. I just wanted to explain that testing. As Dr. Benson mentioned, Solyx relies on anchoring as a fixation mechanism, as compared to the traditional sort of self-fixating tape that traditional sling use. For Solyx, for the sling to fail, we have to test it until those anchors pull out from the muscle. Whereas for advantage fit and Optrix or any traditional sling, all you have to do is test it until, or pull on the mesh until you can just move it slightly and thus render the sling ineffective. So that's really the main difference between the two that you are going to see in the next section.
getting it pulled off of the sling. The sling is still in place. I'm going to pull the remaining side. Over 10 pounds and it maxed out. So what I'd really like to touch base on for just a minute with the video is the fact that your greatest opportunity is your greatest possibility of failure. And as Charlie mentioned earlier, that relates to the fact that this is a mechanically fixated sling. And in doing these pullout studies, it was absolutely amazing to me that literally the device would pull off of the sling before the sling would let go. And that is what you cannot achieve with a non-mechanically fixated sling. And again, as we talked about the procedural steps, the idea that we're going to get this in the right plane, that we're going to penetrate the obturator and turnus muscles perpendicularly so that we have that body of robustness for that sling to connect to is just so important. And the idea that if you don't do the pivot point, do the contralateral swing, and then introduce that barb, that arrow, essentially perpendicularly, that you're not going to get that fixation sling. But when you do, the robustness of this platform is just, it's crazy. It just will not fail you. And I think that when I see folks that have used Solyx and have had problems, it's always related to not doing the contralateral swing and entering that muscle belly perpendicularly so that those fixating anchors can grasp the surface area of that muscle and allow those myocytes to fall in and more or less puff in around that anchor to provide good anchorage. So again, the key thing is just execution in a perfect manner. And I think that the margin of error for the Solyx is high in the fact that when we tighten that, when we adjust that, we do have an ability with a forgiving mesh to set that correctly, but have a margin for a little bit of variety in exact fixation, or I'm sorry, tensioning on that sling and still have it be efficacious. So, you know, one of the things that I wanted to go through with you for a little bit is this idea of transitioning this to a less invasive sling platform that you could do under local. And again, I think that this experiential part of having this therapy available is huge. Again, patients expect perfection with delivery of the tool and with success as far as outcome with loss of incontinence. But it's how you get there that's the key. And how you get there is a patient who says, wow, that was really not invasive. I was happy about the experience. I had a good ability to void afterwards, etc. So many of you that are listening today probably do a fair amount in the office and do procedures under local. And this minimal dissection, this ability of not having to have an exit point, is really emphasized with why that this is the only platform that can allow you to do this under a local anesthetic, in my opinion, and have patients be happy with it. So as we showed earlier, hydrodissection is key. And indeed, I use somewhere between 20 to 30 cc's of a local anesthetic, 10 in the midline and 5 to 10 on each of the paravaginal spaces, just to kind of blunt those apices and to make sure that we're in the right plane and that we have really an avascular space to work. Patients appreciate that, because if they feel anything, what they feel is they feel penetration into the obturator. So you can also actually inject with those lateral injections right into the obturator itself. And I've not found that that's had any effect on pullout or durability or robustness of the muscle belly. And so again, I like to actually know where my sling is going to go before I place it. So by placing that needle into those paravaginal spaces, bending the needle slightly and actually almost bouncing it off of that inferior pubic ramus and feeling the loss of resistance and the fall right into the muscle tells me already where I'm going before I go. Before we actually even get to the point of doing the hydrodissection, preoperatively, we do apply EMLA cream or Recticare cream to the area of the perineum and to that area around the urethra. And we do that about 20 to 30 minutes before the procedure, just to allow a little bit of extra topical anesthetic for patients. We also utilize a little bit of what you might call verbal anesthesia, and that verbal anesthesia is huge. So in my procedural suite, I make sure that there's an individual assigned to the patient who starts with them, who goes to the OR with them, who sits up by the head of the bed to talk to them. The same is true in the office. And that ability to use verbal anesthesia is huge. Beyond that, after we're done with the procedure, we then may additionally treat if they would like a benzodiazepine or something to help with anxiety. But we've really not found that patients need it. And when we've asked patients what is their pain rating when they've finished, on average it's a 0 to a 2, with more patients rating it at a 0 to a 1 than even at a 2. So if you've placed it correctly, if you've numbed that area for dissection appropriately, patients tolerate this exceedingly well. And for me, with the cystoscopy portion of the procedure, we know what the patient's cystometric capacity is before we go to the OR, and we then fill the bladder to that capacity with them awake. And I actually have the patient cough for me. I have the patient Valsalva for me while the second side of the introducer is still in the incision. And that allows me to make any tweaks or adjustments that I need. And I find that I'm able to really set it perfectly because I'm able to have that patient live, real time, show me what they need. And again, for all of you that do cough stress tests for patients, you know what you're looking for. And for me, it's that idea that by simply moving that device slightly with that second anchorage side, you can go from leakage to no leakage and know exactly where that margin is. For patients that are sedated, I use cystometric capacity and do repetitive Crede maneuver. But I think that feedback for you, especially when you're getting used to using this, of knowing that, wow, I watched that incontinence stop right now, is huge. And so I think that that's a positive feedback that you can get and know there's not going to be any further adjustment needed, knowing there's not going to be any further contraction in the mesh, and knowing that you've set it correctly. So again, I hope that so far we've presented a really compelling argument. I think that with the dissection, hopefully you can see that there's no hocus pocus, there's no voodoo to this. It's been proven out with an actual pull-out tensionometer measurement, and you've been able to actually see really where that's anchoring into the muscle. So I found it very insightful, and I hope that you have too. So what we'd like to do at this time is open this to questions. Again, because this is a unique new platform, this is a new way of doing things, there's probably a lot of questions. And no video is perfect. Nothing always encompasses everything that you might want to see. But I think that this does give you a good overview, and hopefully it's a good platform for us to talk more.
Yeah, Dr. Benson, we have a couple of questions for you. One question is with regard to patients with ISD, would you use the sling on those patients?
Yeah. So this is always kind of the group that you wonder, does it work or not? You know, the data that we have found in our practice is that ISD patients respond well to this, with the caveat that if I have an ISD patient, I do it under local and I tension it with them awake so that I'm able to fill them to capacity and ensure that I found that margin of exactly where they need to be dry.
And the second question is with regard to advancing the anchor through, or potential advancement through the membrane. Is that an issue? Do you think it can happen?
You know, I think with the procedure, if you intentionally set out to do the wrong thing, you can place this anchor in a variety of places where it is not meant to be. But I think if you follow those steps and really feel for that loss of resistance, which tells you that you are into the muscle belly, that you're going to find that it's going to be highly accurately deployed. Again, the biggest issue that I see is it's not so much even anchorage into the muscle. It's that were you too superficial, meaning that you're trying to put the anchor into the inferior pubic ramus, or have you drifted too far cephalad, and now you're actually cephalad to the foramen, and you're actually trying to push it into the pubis cephalad to that. So I think if you use simply the marker of that loss of resistance, that idea that you've tapped your knife onto the inferior pubic ramus and you can feel that little loss of resistance cephalad, and you know in your own mind where you're going by using the bony model, all of those things really do allow you to be consistent with your deployment.
One more question. Can you talk about adjustability or tensioning with Solyx?
Sure. You know, one of the things I really like about Solyx, just like I did with Mini-Arc, relates to the nature of the mesh itself. And this is a very distensible mesh. I would encourage all of you that haven't actually felt a Solyx sling to try one just in your hands and see what it feels like. The center portion of the apron is not going to distort, but it purposefully has the ability to stretch further on both arms. And with that, it gives me a fairly wide margin of exactly how I set this, because probably the most common question I get asked is, does this look right? Does this look tight enough? Does it look too loose? And what I'm looking for is essentially just a flat coaptation of the sling onto the urethra with just a slight pillowing. And that is, if you follow the black marks, you feel the loss of resistance, amazingly consistent. And it doesn't matter if the patient weighs 100 pounds or weighs 400 pounds. That anatomy is consistent day in, day out, patient to patient. And so when people ask, well, is it tension right? The first thing that I say is, where's the black mark at? Did you feel the loss of resistance, and how does it look? And it will have a characteristic appearance time and time again. And in fact, Solyx is one of my favorite slings for the very obese patient, for the patient who you would have trouble going through the retropubic space and having enough left on your trocar to get out. For the patient who has a lot of weight distribution in their thighs and you have trouble coming out through the adductors and having that be an easy to distribute sling. This one's excellent because I don't have to exit anywhere. But even in those very heavy patients, this anatomy is reproducible, it's consistent. So if you follow those 3 procedural steps and use that black mark to know where you're at, that tensioning is going to be a fairly much a given thing.
Great. What restrictions do you place on your patients with Solyx?
Yeah, at this point, I've really gone away from really any restrictions other than intercourse for a week while the incision's healing. So my standing joke with patients is I say, test it in the parking lot. So we do a voiding trial before they leave, and they usually are around for a little bit, having a snack, you know, that sort of thing before they go, and their bladder's filling. And I always say, when you're out in the parking lot getting into your car, give yourself a good cough, you know, go ahead and squat, make sure that it's working. So after that, I've really liberalized my restrictions, and we have not found, again, based on that pullout strength, that we're taking people back to replace these slings.
Great, thank you. And the last question we have is, would you consider doing Solyx in the office?
I would absolutely consider doing Solyx in the office. Right now, the only thing that's really preventing Solyx being performed in the office is simply reimbursement and figuring out what model works in those sort of venues. But we have now done several hundred of these under local in a simulated office type setting where we have not had an IV, where we have not had any sort of additional setup or precautions, and patients have done well. So absolutely, when we have the ability to offer this that allows the practice to be reimbursed, that allows this to work within a system of healthcare, this is a win-win for everyone.
Great. Thank you so much, Dr. Benson. That's all the time we have. I want to thank everybody for joining us. If you need more information on Solyx single-incision sling, please visit our virtual booth or reach out to your local Boston Scientific rep. Thank you so much. Have a great weekend.
And thank you, everyone. We really appreciate everybody's effort to attend virtually today. So really appreciate OG's support.